Good evening. Today's MCQ session is in continuation with the neuroanesthesia MCQs that we have been doing for the past few weeks. So, what are the contents of today's session? We will be covering basics of neuroradiology, some questions on DSA, arteriovenous malformation, status epilepticus, and some images related to instruments in neuroanesthesia regarding neuromonitoring and some specific instruments that we use in neuroanesthesia. So the first question is, whenever a patient comes to you in the casualty and you have a CT scan of the patient with you and you're trying to assess what damage has been done neurologically, a basic radiological parameter here is midline shift. So at what level is the midline shift calculated? The answer is septum pellucidum. So as you can see in this figure, a midline shift of more than 5 mm is significant and it is an indication for surgical evacuation, especially for operating for a mass or a lesion or evacuating brain hematoma. So when you consider midline shift, first of all, it is calculated at the level of septum pellucidum. There are two diameters that are considered. One is the M and one is the diameter from external end to the septum pellucidum. So the first diameter is divided into two halves and the distance S is subtracted from the first distance and thus you can calculate the midline shift. So the gravity of midline shift determines whether the patient will undergo surgery or not. So in this case, the midline shift is being calculated in a patient with subdural hematoma. Coming to some questions on DSA. So whenever you are posted in a DSA lab, you have to adhere to some radiation safety measures. So in this question, they're asking all of the following are radiation safety measures except. So one is collimation of rays, yes. Using last hold image to plan further action, yes. So what they do is when they take a shoot, they study the last image that is available so as to reduce the number of shoots. Then pulsed fluoro with the lowest dose to be used. Again, this is one of the tactics of radiation safety. And the meters which are given in the DSA lab, including the technician, the nursing staff, anesthesiologists, and the radiologists themselves, they have to be worn above the lead gown, not below the lead gown. So this is the answer of this question. So what are the standard precautions that must be taken to prevent radiation exposure? There are several design elements that are available to aid the fluoroscopist or the interventional radiologist to reduce this radiation exposure, and learning to effectively utilize them is critically important for the fluoroscopist. So many of these factors may be equipment specific, and hence specific training for specific equipment is essential for the fluoroscopist. So one such method is pulse fluoro, which activates the tube intermittently continuously, and this greatly reduces the dose. So the lower the pulse rate, pulses per second, the less is the radiation exposure. Now, for the most of the procedures, they have any time-sensitive component, so the lowest pulse setting can be used in them. Thus, we are reducing the time factor. An additional feature to reduce the time factor would be using the last image hold method. This allows an image to be displayed that can be used to plan the next portion of the procedure. So you can study the image you have already taken instead of taking unnecessary repetitive shoots of the same anatomy. And again, collimating the X-ray beam to the smallest size possible. This can be done one of the methods as a standard precaution to prevent radiation exposure. So when you think of radiation and radiation safety, one common terminology that is being used is ALARA. So it is as low as reasonably achievable. So most healthcare workers who are posted in a DSA suit, they're familiar with the ALARA concept, which means keeping the radiation exposure as low as reasonably achievable. So here what can be done? Keep the time and procedure and the radiation exposure as short as reasonably possible from the X-ray source. Then increase the distance of the healthcare worker as far as reasonably possible from the X-ray source. Then we have to utilize safety devices and shielding whenever possible. And we have to be familiar with the appropriate use of fluoroscopy and specific techniques to reduce the radiation exposure for both the healthcare workers as well as the patient. And special precautions have to be taken if the patient is pregnant. You have to accompany the patient with a lead apron on the abdomen, like an abdominal shield. And basically, unless absolutely necessary, these patients are not to be subjected for any radiation procedures at all. So, whenever you are going for a DSA procedure, there are femoral catheters in place, and a lot of heparin is being administered in the patient. Now, in case of an aneurysm rupture or sudden bleeding, we have to reverse these effects of heparin. And the drug or the antidote for heparin reversal is protamine. And there's a specific dose of how much protamine is to be given for per 100 international units of heparin, and that is 1 mg per 100 units of heparin. Now, when suppose a patient of aneurysm is on the DSA suite and you are doing a coiling and suddenly there's a rupture of the aneurysm by the microwire that is being used or the coil that is being placed. So the radiologist or the interventional radiologist or the neurosurgeon, they will ask for immediate administration of protamine for heparin reversal. Now, these procedures are highly heparinized procedures. They are done with placement of the arterial sheath at the beginning of the procedure in the femoral artery. Typically, the IV dosage of heparin is 3,000 to 6,000 units or 70 units heparin per kilogram of body weight. Now, the dose of protamine which is necessary for heparin reversal is 1 to 1.5 mg per 100 units of heparin, and it is to be injected by the intravenous route with a maximum dose of 50 mg. The blood pressure here should be immediately lowered to a systolic blood pressure of less than 140 mmHg to reduce the ongoing blood loss. So, a controlled hypotension may be favorable in cases of rupture of aneurysm. Now, balloons can be used to occlude the point of hemorrhage if it is visible, and acute ruptures, they are also managed by placing an external ventricular drain at the bedside to relieve the acutely raised intracranial pressure. So all these modalities of treatment with immediate reversal of heparin by protamine is necessary to salvage the patients undergoing rupture of aneurysm. So when we come to aneurysm and SAH findings, what are the CT scan findings that we see in a typical SAH patients? That is hyperdensity of the basal system because of the blood clot. So density is a terminology that is used in CT scans, while intensity is a imaging specific terminology used to describe MRI reports. So on acute CT, in acute hemorrhage on a CT scan, they present with hyperdensity in cases of subarachnoid hemorrhage in the basal systems. So, distribution and the amount of SAH may suggest approximate location of the aneurysm, while the CT angiography and the DSA, which include the 3D rotational angiography, they confirm the exact size, width, and configuration of the aneurysm neck and the dome. Now, this information is critical to allow the clinician to make therapeutic decisions regarding the best approach, that is surgery or interventional neuroradiology. So now you can see in this image what pathology this image, DSA image is suggesting. It is basically showing this abnormal bulging of vessels, which is a basilar tip aneurysm. So a ruptured basilar aneurysm, basilar tip aneurysm, it is very risky and it may result in a fatal subarachnoid hemorrhage. Now, why? Because owing to the proximity of the brainstem, it is difficult to attain adequate exposure in these patients. And because the basilar tip has been ruptured, it is very difficult to expose this part of anatomy due to crowding of arteries in the region. And then, therefore, surgical clipping may be a challenge. So, owing to the straight course of the basilar artery, the apex position of the artery, and development of embolization techniques, basilar tip aneurysms could be an indication, a good indication to tackle them by the endovascular navigation and